when working in the PCBH model, and essentially don't let anything like trip you up, just keep going. And so here we go. So admittedly, this will be like the nitty-gritty basics. And the rationale for that is that I always acknowledge that people are approaching any level of integrated care from different perspectives. So I don't want to assume that we are all at the same place. If you've attended trainings with me before, you know you can pull up the chat box, you can ask me questions, drop it in there. We can wait to the end, but whatever works is cool with me. So we're going to talk about the foundational principles of the PCBH model. And so, yes, I know that this is a really big, really like wordy slide. In fact, my next slide says, that's a lot, right? So yeah. And so I will not read all of this to you, but I want to make sure that we talk about like the fact that the main goal of the PCBH model is to enhance the primary care team's ability to manage and treat problems and conditions, and that it's based upon a couple guiding principles, including that it's a generalist approach. It increases accessibility for patients at the point of care. It's team-based. People who function within the PCBH model should be functioning at high volume. Behavioral health clinicians, behavioral health consultants, whatever C word you want to use, are educators. And this model really emphasizes that behavioral health care is a routine component of primary care. And so we're going to talk more about like, how do we break that down? And so as I stated, that was a lot. It was wordy. I will never, ever, ever read to you like a slide like that. And so just wanted you to have it. And just so you know that came from writer Dobmeyer and Hunter's article in 2018, where they did a thorough reference and literature review of pretty much every article they could find that talked about what PCBH was, because they wanted to find an operational definition of it since it had been used by 30 million people, 30 different ways. And so this was their operational definition. So I want to spend time breaking it down for us today. So remember, we talked about those core principles that if you look at it, it says gather. You know, it's pretty cool that like, you know, all the principles actually make an acronym. And I don't think we can do anything in psychology without, you know, acronyms and things like that. So this is right on par. But then some of the underlying principles that we need for this to be successful are that like our visits are focused, we are flexible, and we focus on functioning rather than just symptom reduction when we're providing care in the PCBH model. So let's start with generalists. BHC scope of practice, common referrals, anything that walks through the door. I think that's one of the coolest parts and simultaneously one of the scariest parts about working in the PCBH model, the primary care behavioral health model, because no one teaches you how to be a generalist when you're in school. Like you learn how to follow those manuals, those protocols. You become an amazing clinician for like two things. But in the PCBH model, anything that walks through the door, you're like, absolutely, I know what I'm doing. Even if you have no idea what you're doing, absolutely, I can do that. And so you'll see here, this is just some ways that the behavioral health providers can work with the primary care team members to address concerns. And I just want to highlight the last part, any health behavior change, meaning there is no wrong warm handoff. There is no wrong answer. Anything that involves change is appropriate for BHC functioning within the PCBH model. This also helps when you're trying to teach clinicians how to utilize the behavioral health clinician. You know, I came across even internally, you know, I'm working at Cherokee Health System, so we do this like we breathe, but we have a lot of what I call pandemic hires who did not get the benefit of practicing in real time in the clinic using the PCBH model. And so they practice differently than what we were used to. And I was doing a coaching session with them because yes, we do internal trainings too. Um, and one of the PCPs was telling me how much time she spends triaging a patient concern to determine whether or not like I would want to see that patient or whether this is something that can be deferred for later. And she said, I'm trying my hardest, to not put too much on your plate. And I was like, can you fill my plate up, please? Like, I need you to not spend your time triaging. Any health behavior change is totally okay for you to tag me in. And she was like, really? I don't have to determine whether or not like I can just ask them to come back later. I can ask you for anything. I was like, please ask me for anything. We will determine together as a team and with the patient whether or not like this is urgent. My goal is to see you right now. Sometimes we know life happens and there's 6 patients waiting, but either way, like don't triage for me. Like just pass it. And her response was, I did not know that. I've been spending these last 2 years trying to decide which ones go here and which ones go there. And again, our pandemic hires never had the benefit of seeing us in real time because we were working remotely a lot. But it's just a really good reminder that like anything that involves change, we can help you with that. Here are questions that I commonly get when I'm like saying anything that walks through the door. Well, what about competence? If you are like me, I'm licensed as a psychologist, which meant I spent a lot of times reading the psychological ethics code. And it says, a clinician psychologist should not um, start doing a practice with a theoretical orientation or a skill unless they've had 900 years of training, they've had supervision, they've had 20 million hours of observation, and they can, confidently state that they know everything there is to know about that new skill that they want. And yes, you need to be competent, but when you're working in primary care, we don't have 6 months for you to read every single empirical study about the skill that you're being asked to address or about the health condition that you're being asked to address. And so even though you may not be an expert in it, yes, we see anything that walks through the door. My best example of this is I had a PCP. We've been working together about 8 years now. And she said, hey, can you see the patient in room 9 for assistance with AFib and anxiety? And I was like, yes, I can. My next question was, well, do you need your exam room or should I bring her into this office? She was like, you can stay in the room. My very next question was, what's AFib? But mind you, I said yes before I even knew what the heck AFib was, but I didn't need to know everything there was to know about it because I huddled with the PCP before I went in. They gave me the nuts and bolts, say this, don't say that. This is essentially what it is. And I was still able to go in there because I know how to handle anxiety. I didn't know everything there was about AFib, but I was able to get in there and do some things. So it's okay to feel anxious about not knowing everything about the thing that you're being asked to address, but guess what? You'll be fine. Okay. Other people say, well, what about trauma? Yeah, what about it? If somebody walks through the door and they're experiencing trauma, there's something that the behavioral health clinician can do for them while they're already there in the clinic. What about suicidal ideation? And my question again is, what about it? If the person walks through the door with thoughts that they'd be better off dead, we say, yes, I can to it, just like anything else. Kiddo concerns, tantruming, bedwetting. Absolutely, yes, I can. Even if you're not a kiddo person. Hallucinations like psychosis, absolutely. PCBH is an appropriate place for that because data tells us that most people with these conditions and mental health concerns are only coming to the primary care provider. They are not seeking care from a psychiatrist or a therapist or anyone else. So yes, we can absolutely address that while the patient's there today. What about drug use? Yep, you can absolutely assess for readiness to reduce or quit or assist with, providing resources for any type of treatment. And so I've heard pretty much every question, what about this? What about that? What about this? And my answer for it all is, yep, if it walks through the door, you can handle it in primary care. That doesn't mean you stop at primary care, but we never say, oh goodness, no, I only learned how to do CBT with adults so I can't help that child with their tantruming behavior with their caregivers. That would be the equivalent of a PCP saying, you know what, I only deal with hearts, right? And this person said that they have neuropathy in their foot. I can't deal with that because I don't do feet. I only do hearts, okay? I know you came to primary care for your medical visit, but I can only check your heart. I can only listen to your blood pressure. I cannot address your feet. And if that sounds weird, it should, okay? So my guiding principle for like the generalist approach, when in primary care, do what primary care does. Um, I love watching my primary care colleagues when they teach themselves something real quick, fast. You know, they'll go see the patient, gather as much information as they can, and then come out and say, I have no idea what that was, but I'm gonna use a resource like Up to Date or a colleague or something, and I'm gonna find enough to at least know what lab to order or what referral needs to be placed. But they aren't spending 12 hours at a CE to get full competence on that thing. They're not telling the patient to go because they've never worked with that before. They go somewhere, they read something real quick, fast, and then they go back in the room. We get to do the exact same thing. The patient's there. We may not have expertise in it, but we have resources that we can use. Okay. When we think about PCBH promoting accessibility, ideally, we are going to say, yes, I can, and see every patient on the same day. And I know life happens. I know that that's not always possible, but the goal is to say, yes, I can every single time, a team member asks for a patient to be seen. And so, yes is always the answer. Does that mean it's like, yes, I can see you right now. I am walking toward the room right now? Not always. It could be absolutely, I'll see that patient. I have two waiting to be seen. If the patient needs to go to labs first, please have them do that. If the patient is okay waiting about 30 minutes, I'm happy to see them then. If the patient would prefer not to wait, and if they're done with every other part of their visit, please offer to schedule them, but I will see them today if they want to. But the answer is always yes. It's never a no, refer them, or no, schedule them. It's always a yes, okay? Warm handoffs help promote accessibility. So when a PCP asks me to see a patient, yes, I can. And I might give the caveats for when I can get to the patient. But then there are a couple different questions that I ask immediately after, like, where is the patient in their visit? So have you seen them yet? Are they waiting for labs? Do they need the nurse to come in and provide any education? Are they ready to go on the last stop? Because that lets me know if I have another patient waiting to be seen, how much time I really have before I have to be responsive to that patient who I just said yes to. And then I also ask, do you need your room? And by that, I mean, can I see the patient in the exam room, or are you backed up and need to get another person roomed? And so you'll see that in every clinic that we have, there's at least one designated BHC office for that purpose. So if the PCP needs that exam room switched over, we can pull them back. But our designated room is in the primary care workflow. So the office I'm in now shares a wall with exam room 7 and exam room 6. Like, I am in the primary care workflow. Patients don't have to go up the street, down the corner, around the block, and then up some stairs to get to the BHC office. They go 2 doors down, and they stay within the primary care workflow, even if I can't see them in the exam room. Ultimate goal is the same in the exam room, but again, life happens, okay? Words matter. So I strongly recommend that we get comfortable calling ourselves clinicians or consultants, not therapists. Because when you call yourself a therapist, patients have an expectation of what service they're going to receive. Although I am licensed as a psychologist, I don't introduce myself that way first. I say, hey, my name is Dr. Winford. I'm a member of the primary care team, and I work as a behavioral health consultant. Although I'm licensed as a clinician, I don't do therapy like most clinicians do. Why do I do that? Because, again, I want to be a part of the team. I want to reduce any stigma and barriers I have. I am still going to tell the truth about what my training is, But again, we're in primary care and we want to set expectations that we're not going to have a 45-minute therapy session. I'm a member of the team. I'm going to focus on a very specific thing, and then we'll roll out. We'll make that plan and figure out how we go next. And the schedule matters. I recommend only scheduling 30-minute tops, no 45-minute visits in PCBH, because then it's easy to switch between being always available and then being behind a closed door doing a session. And I know that a lot of organizations don't have the bandwidth or the workforce to not do both, but I strongly recommend having some clear boundaries about what time are you a BHC, what day are you a therapist. Therefore, there's a clear message being sent to the team about who you are and what role and function you're playing on the team. I've had to learn to read the room, read the clinic, so that way I could put what we call on-demand slots. Like Hopper and them used to have like video on demand. Remember, it was a TiVo or whatever it was when it first came out, and you could record your shows, and it was like a big deal to be able to record your show and then go on demand and like watch whatever show you want to whenever. We think about on-demand slots like that. Like, we're going to reserve this space and we can be used as needed. And so when I talk about how words matter, my favorite analogy to use is the firefighter versus the arson investigator. Okay. So ideally, this will never happen ever to anyone. However, I want you all to imagine that, you're in a burning building. Maybe you're on like the 5th floor. For some reason, all the doors are locked, all the windows have bars on them. Like you just can't escape. You've done like the doorknob test. It's too hot. Like you can't get out. Like you were stuck in the 5th floor of this building with no foreseeable escape. So the question I like to ask people when I give this scenario is, in that moment when you're stuck with no way to get out, what will be most helpful for you? Would you like someone to come in and say, let me tell you this, I am going to be the best arson investigator I can be. I'm going to find every single electrical socket, and I will look at all the wires, and I will tell you exactly what the cause of this fire is. I'm going to find it out for you. Okay. Don't you worry. I see that the fire's still burning, but don't worry about that, because I'm going to find the outlet, the circuit breaker that caused this fire. I don't really want that right now. I need you to like teach me a skill, give me a tool so I can get my butt out of the burning house. So I like to think of myself as a BHC, as a firefighter. I'm going to bring tools to patients. I'm going to teach skills to patients. I'm going to give them the ladder and show them how to climb out the window. I'm going to come in and be like, all right, back up. I'm going to do it this first time, and then you do it after me, whether I'm breaking something, whatever the case may be. And keep in mind that the fire doesn't always have to be a crisis. The fire can be diabetes management. Okay. So like, I don't need to go in and say, what was your meal habits like when you were 3, when you first noticed that like diabetes would be a thing? I don't need to know that. I need to know, how's it affecting you now? What skills do you have? What skills do you need? How do you manage it now? How would you like to manage it? But either way, I'm a firefighter, never, ever, ever an arson investigator in my role as a BHC. I'm thankful to work in a place where we do have arson investigators on our team. So if and when a patient is ready, if that's what they want, we can not only teach them how to use that fire hose, but we can also link them in with the arson investigator who can get at the underlying root cause of the symptoms and distress that we're seeing. But I will never be both of these people ever, especially not in primary care. Okay. It's just like you don't have a cardiologist in your primary care clinic. You might, if you got like fancy stuff and you can refer in-house, but for the most part, even if you did study cardiology in school, you will never become a cardiologist just because the person has a really high blood pressure. Even if you feel pulled to pull like all your cardiology skills and talents out, you're still going to be a primary care provider, even if you're dealing with a heart thing. I will always be a BHC, even if I'm dealing with trauma. I will always be a BHC, even if I'm dealing with depression, anxiety, drugs, doesn't matter. And if and when patients want more, I'll come up with the arson investigators. So the other part is that PCBH is team-based. I always put patients as the primary member of the team. They always get listed first whenever I talk about it, because patients are the most underutilized member of the entire team. We often forget that just because we got numbers and letters behind our name, it does not supersede the knowledge that patients have about their own lives and about their own experiences, about their preferences, about their values. And I know we can cause people to get stuck when we don't listen first or ask, what is it that they tried? What's important to you? I can't assume that just because I want you to stop drinking, that you're ready to stop drinking. And if I only come in with a plan for you to stop drinking, but all you want to do is, lose 5 pounds, like, we are not on the same page. So patients are first, they run the show. Other people that we don't always think about as being part of the team: front office staff, our IT team, our phlebotomists, they're all part of the team. Why are they part of the PCBH team? Because when we think about some of the functions of like a primary care team, identification, communication, collaboration are some of those functions. My front office staff has never given me an incorrect warm handoff. They see patients when they check in, when they check out, when they call, when they schedule, when they reschedule. So they know patients. They know what's typical for them. And they can say, hey, Dr. Winfred, like, Dr. Carter's 2 o'clock is not on your schedule, but something's different today. Just want to give you a heads up. And I'm going to say, thank you so much. I'll collaborate with Dr. Carter and the nurse. 9 times out of 10, I'm going to see that patient that day. I'm not going to say, oh, you're not the BHC. You can't tell me that a patient needs to see BHC. Yes, they can. They can absolutely inform me of a patient's need, and then we triage it back here to determine who's going to be the best person to meet that need. So nurses and front office staff, real MVPs, like, they know everything. They know our patients. Nurses know what's going on with the workflow. So when I say, where is the patient in the visit? Nurses are typically going to be the one to answer that for me, because they are running the show, telling you who's in what room, what do they need, things like that. They are absolutely part of the team. We have community health workers and case managers who essentially function outside of the 4 walls of your clinic. They are part of the team because they bring in information that you would never see in the clinic. And then, of course, we have the primary care providers, the BHCs, right? They're all part of the team. IT is part of your team, because if you don't have a functioning like EHR or some sort of, mechanism to chart, submit coding and billing, then like you can't do nothing really. And so I routinely send my IT team Pop-Tarts and chocolate, because that's what they like. And I need to keep them happy, because if they're not happy, I'm not happy, because they keep the system going. And then for us, we have the continuum of care available at Cherokee Health System. So the psychiatrist, the therapist, any other specialty provider, they're still part of the team. They're just not in the primary care setting for us. And keep noticing how I say, if the patient is ready and if that's what they want, then we can get them to that higher level of care. I think a lot of times we get stuck on diagnosis alone as the determining factor for what level of care a patient needs. But in the PCBH model, I could care less what the diagnosis is. We need to look at the patient's severity, their readiness to engage, and like, what's the treatment plan, what you're working toward. Just because they have PTSD doesn't mean they need or want to go to therapy to do cognitive processing therapy. Like, that's an assumption we make that we got a break. But the team members are there when the patients are ready for that. Okay. We can try to inform them, like, I really recommend you do this, but again, until they're ready, it doesn't matter. Okay. High volume. So, the therapists in our system see about 7 or 8 clients a day. BHCs, we see 12-ish per day patients. And notice how I said clients for therapists, patients for BHCs, because we use the same language when primary care, do what primary care does. So unless my PCPs start calling patients clients, I'm not calling them clients either. But that's a big jump for people who've only ever learned to do 45-minute, 50-minute sessions. So to go from 7 to 12 can be a little bit overwhelming. My schedule for tomorrow in its current state, because I'm not going to hold on to it, it's going to look different by the time I get here tomorrow. But tomorrow, there are already 13 people on my schedule. Most of them are paired with primary care provider visits. So we've already like coordinated care. I have 3 on-demand slots remaining. So like I can get 16 total patients in a scheduled spot, but we can also override it and double book if we need to. But I'm coming in with the expectation that 13 could show tomorrow. And I could say, yes, I can 3 more times or more. And that's just the way it is. Like our PCPs see about 18 to 22 a day. So my schedule is like their schedule because I'm in primary care. So this is what I mean by a high volume schedule. This is from 2013, y'all, and I'm not even gonna lie, like things have changed. And the dates are off, but we're gonna use our imagination with this, okay? So the template still looks very much like this. So if you notice on the morning, which is on the left, we schedule patients every 30 minutes only. Okay, there's no 45-minute, but we always schedule every 30 minutes because that helps us to make sure that we control. Yeah, we do have next gen. Again, it helps us to kind of manage the thing. Our goal ultimately is that we're going to be seeing patients about 16 minutes. That may seem like a really weird number, but it's a 90832 billable encounter if we're doing a follow-up. If we're doing a 90791, which is an intake, it's not time bound, but we think 16 minutes in general. And if you were to pretend that the screenshot next to this was like later on that afternoon, you can see how different the schedules look. And it is not uncommon for our schedule to start looking the way it does on the left and end the way it looks on the right. People scheduled in 15-minute slots and not even on the actual appointment times that like some of them were there. But this is high volume. Okay. And that's why I said in this current stage right now, today, my schedule has 13 scheduled, and it's a combination of independent follow-ups and coordinated PCP visit follow-ups. Who knows what it'll look like when I get here at 8 o'clock tomorrow? There could be 16 people up there. There could be 5 people up there. I just show up. Like I don't even plan. I just show up and I'm like, all right, let's do this thing because it can change. All right. But flexibility is really, really, really what it is. We jokingly say, but seriously, schedules are the approximate indicators of a patient's proposed time of arrival. All right. So yeah, they may have an 8 o'clock appointment, but like if they show up at 8:10, come on back. Yes, we've technically lost 10 minutes of their appointment, but it probably took that long for them to get from the bus stop to the door or to fill out the registration or to check in, whatever the case may be. For PCBH, schedules are not set in stone. So again, you keep hearing me say, yeah, my schedule tomorrow looks like that right now, but when I get here, it's probably gonna be different. And I gotta learn to hold that very loosely. I can't hold my schedule tightly. And if having a standardized schedule every single day is your jam, PCBH is going to be really difficult because it can look so different depending on what day it is, literally what season it is. I have way more warm handoff slots in July and August because the kiddos are getting ready to go back to school. And so they're going to have a whole lot of well child checks. And, we're going to be doing a lot of ADHD evaluations, sending home the basque and teaching skills to the families to reinforce attention and things like that. I know not to have a whole bunch of scheduled appointments then. Your schedule will change day to day, hour to hour, minute to minute. You never know when you'll be asked to see a patient when yes, I can is the response. And I just want to go ahead and for anyone who is like just dipping their waters into PCBH, dipping their toes into PCBH water, I'll pop the bubble now. You will be late. You will run behind and the world will not end. Okay, that's usually a big, big, big thing for some people that again, the patient's scheduled at 8, so they need to start at 8. The next patient's scheduled at 8:30, so they need to start at 8:30. And I'm like, I started at 8:10, I was done by 8:28. We're doing just fine. okay? Because schedules are the approximate indicators of a patient's proposed arrival time. Like we want them there by that time, but life happens. So you will be late, and that just is what it is. Take a few deep breaths, but you're gonna run late, and that's fine. Okay. The other part about PCBH is that like the BHC gets to serve as an educator to the primary care team. And so what do I mean by that? Every new hire receives a script based upon their role that tells them how to introduce the integrated care model and how they introduce each of the team members. So whether it's a CHW, whether it is a BHC, whether it's, like the front office staff, we give them scripts for how to introduce every key team member because nothing says, team-based care better than when you get 12 different descriptions of the type of setting that you're in from each of the 12 different people that you had contact with today. So we give everybody a script. Now, does that mean they need to take it and say, hi, my name is and my role is no, because that's weird. We want them to make it their own, but there's some key pieces that we want every member of the team to be able to share. My team knows how to do motivational interviewing. They know how to use a change ruler. Like they are on it. They know what they're doing. If y'all, I had COVID and this is my first day out of the clinic in 2 weeks because it knocked me down bad. But I was able to collaborate. I talked to the PCPs and they're like, I did the risk assessment when we think about like, suicidal ideation. They have, thoughts, but no intent plan means they don't have access to weapons. Like they can handle it. Or they'll say like, you weren't in the clinic today, so I asked this patient to see you when they come back to follow up with me. They're currently in like, the pre-contemplation stage of change, but like, I know you can get them to contemplation at least. Like my team is bad, okay? Bad means good. They good. Goal setting. We've role played in practice. Like, what's a realistic goal for you to set with your patient? Like, you cannot change 12 medicines and expect them to take all 12 the correct way and then come back with like improvement in all the different conditions that you change the medicines for. That's not realistic. You might say, all right, which of these things are we going to prioritize today? Okay. And then let the patient help you do that. Again, the team is amazing. And I hear it because our walls aren't always as thick as they need to be, but we have the little sound machines as much as possible. But I can hear like the motivational interviewing and goal setting in action because again, room 7 is on this wall, room 6 is on that wall. I am in the primary care workflow. My patients and PCPs know how to act now, feel later for behavioral activation, and they say it just like that. Agenda setting, we've made some progress with them working with patients who have really long lists of concerns, so that way neither one of them feels overwhelmed. So they know that like it's okay to say, our visit today is 15, 20 minutes. So if we only get to talk about 2 things, what are those 2 things that we need to talk about today? And hypothetically speaking, we only get through one. What's the one thing you and I can take care of today? I hear that agenda setting when they go into the room. It works out really well. Like if I go in first and do it and then come out and say, all right, like such and such in room 7 wants to talk about diabetes first and then talk about weight management second, understands that diabetes will be the priority. So the PCP can go in and say, hey, I heard you want to talk about diabetes first. Let's go. Agenda setting. And it works really well. And again, I don't have to be here for a PCP or for a patient to learn how to do a relaxation strategy because we've taught the PCPs how to do it. And so like, even if I didn't know what AFib was, and didn't know how to manage anxiety, the PCP could have done it. And in fact, like the interesting part about that warm handoff was that I did the exact same thing the PCP did, but said it in like behavioral health terms. She was like, you just need to take a couple deep breaths and then we'll go from there. And I was like, perfect. We're going to talk about cue controlled relaxation and pursed lip breathing, diaphragmatic breathing, teaching the same thing, but reinforcing it. And I didn't have to be there for it. So patients' needs are going to be met, even if I'm sick and at home or out of town or out of the clinic. They don't need me to meet these needs. Same thing with them. I can read a CBC like nobody's business, right? Will I tell a patient what their lab result is? Absolutely not, because that's not my role. But I can look at those labs and know exactly what's happening. I know what medications do. I know starting doses for pretty much all the medicines because I listen and talk and I learn from my PCP colleagues. Again, I know better than to open my mouth and say, here's what you're gonna do, because that's not in my lane. But when patients say things, I can answer it. And I can say, you know what? We gonna talk to PCP da 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 first. I said, but what you might want to do is consider this when you're learning how to take that. Think about this. Most people's A1C, we want to keep it under, 7-6%. Yours is at a 15, so we got somewhere to go. Again, I'm not given the diagnosis of diabetes, but I know how to talk about it. And so we're an educator, we learn, it's pretty cool. And then lastly, when we talk about PCBH, this model really sets up the framework for behavioral health to be a routine component of care. All right. So like there's nothing weird about it. There's nothing new. Like this is care, righty? And so here's what I mean by that. I have heard some really awful introductions of team members, like really bad, y'all, including a version of this. We have this shrink who sees people who, like you, they fail their depression screening. And so we can't let you leave until you see them. And if somebody says that to me, I would say, you ain't keeping me nowhere. I'm going home. Like, what do you mean I can't leave until you see them because I failed a screening? No, we're not going to do that. I've heard versions of that, and that makes this part of the care really different and distinct and stigmatized and weird, and we don't want that. Here's how we ask PCPs to introduce us, okay? I have a member of my team who's an expert in stress and depression management. They've been really helpful with other patients who have shared similar concerns. I'd like for you to meet with them when we finish here so they can help me help you. Is that all right? See how non-weird that is compared to you failed your depression screening, so I can't let you go until you meet with the shrink. Like that just feels really uncomfortable. And so this is the guiding principle. Don't make it weird. Okay. And why do I have a phlebotomist there? If you notice this language here, you could easily fill in like lab. Okay. I want to take you to the lab when we're done because I really want to know more information. And this type of lab has been helpful for other patients with similar concerns. Um, I want you to go ahead and agree to get those labs so they can help me understand a bit better how I can help you. Is that okay with you? Not, listen, everybody who comes in here and says that their blood pressure is too high, they just failed that screening. And I mean, I need to go get some labs to see what your cholesterol is like. And I know you probably don't like that, but I mean, like, because you failed your blood pressure screening, you can't leave until we get you some labs so I can see what else is going on. Like, no one wants to feel threatened. And so just make it real basic. Like, I got a member of my team, they do this. I would really love for you to meet with them when we're done. They'll help me help you. I need you to get some labs on the way out so we can get some more information so I can understand better how to help you. Talk the same way, but don't make it weird. Okay. And so we have reached the portion where we can kind of talk about like what this has looked like for you, any challenges you may have experienced with your implementation or as you're preparing to implement. But let's talk. And this is usually the coolest part when everyone's like, I will not. You said talk. I'm going to look at you in silence.
I have a question, Emily.
Yeah.
In our program, we are learning about PCBH, the providers and the leadership is being introduced to that model. But what we're noticing is that before we're fully staffed, when you just have maybe one provider in a huge clinic, they end up just getting used for crisis. How do you teach
Yes.
providers when their experience doesn't match that we can do so much more than just assess
Yeah.
for suicidal ideation?
Yeah. So part one, crying does not equal a crisis. And you can ask any PCP, they know how to repeat that. crying is not a crisis. That means people are normal. They're human. They're having reactions. So I start with that. But the other thing that I think can be incredibly helpful is as much as possible, try to shadow your primary care providers and then give feedback with the patients that you see. So when we onboard new BHCs, before they shadow me or like see any patients themselves, they spend about a week or two just shadowing PCPs and talking after or in between curbside huddles about like what was going on. So what was the medical condition? What could be a behavioral health factor, and how could that BHC have contributed to the patient's plan? And just get used to talking about it like that. Like, oh, in that last one when you were talking about COPD, I'd be happy to talk to this person about tobacco cessation if that would be helpful. Like just dropping in the things you know how to do well, make it casual. I mean, you can also do informal or formal like educational sessions where that you weren't up here, I don't think at the beginning, but when you get the PDFs, there's a list of like um, commonly identified concerns that BHCs can help with. And it is everything, including the kitchen sink, because that last line says any health behavior change. So just getting your team used to not thinking twice. The other thing I do is I tell PCPs, I don't want you to triage whether or not the patient could benefit from BHC. Anytime you get to the point where a behavioral health thing comes up, I want you to say, you know what, I got a member of my team who's an expert at the importance of clipping your toenails, and I'm going to have them come in and meet with you. Okay. Yes, I've done those things. I've been an expert in wearing pants before, right? Turns out the person had early onset dementia and thought it was okay to go feel the breeze outside in the morning, but like I don't want them to have to determine if this is an appropriate referral or warm handoff. So I tell them your threshold is in the basement. Any behavior change, I need you to tag into that thing. And a lot of times it's going to be, I don't have time for this, like whatever. That's why I say if you can identify a space to pull the patient out that's still within the primary care workflow, that way you're not clogging the exam rooms, because that's a big deal with implementation. Like you're taking too long. 12 minutes isn't that long, but that's okay. But if you got a place to pull them, and just give good feedback. 3 pieces of feedback I give every time. What's my diagnosis? What am I going to do about it? And what, if anything, do I need the primary care team to do to support that? So patient meets criteria for depression and in the in the moderate range, we talked about a behavioral activation plan, and they would like to discuss medication management if possible. But I'm not saying stop sending to people who are crying to me, even though that's what I'm screaming in my head. But like just really being intentional about the communication, shadowing, things like that. Long answer, but hopefully you got something out of that. Okay. Aaron,
Hi.
hey.
Thank you so much for your awesome presentation. Really appreciate it. And I had a question about ADHD screening and diagnosis. So
Yes.
I work in internal medicine, so we don't actually see any children. But I'm in an area that access to behavioral health for many of our populations wasn't something that was available when they were younger, so there was a lot of misdiagnosis.
Mm-hmm.
Um, how are you doing that in such a brief period of time?
So you gave me one of those, what about? What about? So I had a slide where I was like, what about this? What about that? Can you do that in primary care? Yes. It may take more than one visit. It may take a follow-up. But depending on the age, if they are still in like college age, we do have access to the BASC. We can send that out. Um, Unfortunately, we don't prescribe stimulants to adults here. And so a lot of people get discouraged that we can't give them medication to address it. And so what we oftentimes have to end up doing, we partner with the University of Tennessee, their psychology clinic, which is a training site, but they can do really reduced cost evaluations. We often have to collaborate with them for that. But also I can just do just a regular assessment as much as possible. Like, tell me, when did you first notice these things happening? Give me an example of a time when, like your distraction had a negative
Mhm.
impact. Tell me about work. Do you remember what it was like in school? You know, like, do you remember your teacher saying, sit down, stop running around, but really just trying to pull out what you would get if you had a formal assessment to give them, ask about the more than one setting. Um, and sometimes it may just be a provisional diagnosis, right? If you don't have the thing, but you know the symptoms of ADHD when you hear them.
Right.
And so I do a lot of just clinical interview questions that way. But if you call me at 3 o'clock in the morning and ask me to tell you the difference between like bipolar disorder with psychotic features versus like schizoaffective disorder bipolar type, I could tell you and go back to sleep in like 3 seconds because I've overlearned the DSM. So when you
Mhm.
overlearn it, you can do anything in 16 minutes because you ask very specific questions that will quickly rule something in or out. If an adult tells me ADHD, how often have you used any type of stimulants, including caffeine, cocaine, anything like that? And if they're like, oh yeah, I did coke, I know that I can probably not go as far with the ADHD piece as I would need to for someone who has no history of using any type of stimulant in that regard. But you find the key, most sensitive questions that can get you where you got to go.
Thank
So
you.
like memorize that thing and maybe you put
Mhm.
like a couple post-it notes on your computer that says, if they say this, I'm gonna ask more questions. If they say no to that, don't ask. I do that with bipolar disorder. The two most sensitive symptoms, the decreased need for sleep and increased energy. If they tell me they've never experienced that ever in their lives, I stop. Like I don't have to keep going for bipolar, you know, for the most part. And so if you can find those sensitive questions like that, if they say they've never had that ever in their life, you can like fall back a little bit and know to go a different way. Tori,
Hi,
hey,
I'm Tori. I'm a BHC at a clinic in Columbia, Missouri. So I'm a state over. I'm laughing because I'm like, right, you asked about the sleep thing. If they say no to the sleep thing, then we're not going to go down the
because everybody
bipolar.
has bipolar disorder. And I'm like,
I
y'all, do you
know.
realize the prevalence is like so tiny that they can't all be here in this clinic? Like it's not
Mm,
statistically possible that you all have bipolar disorder.
true. This is true. Braylar for all. Anyway, you might have touched on this at the beginning. I had to get on late, but who supervises you? Or like who's in charge? And I ask that because I'm in a large organization and they have a hard time like figuring out where we go. So
Mhm.
all of my supervisors have been therapists and they
Mhm.
are lovely, but they do not know what a BHC does. And it's really challenging because I do a lot of like educating them on what a BHC is.
Mhm.
Um, so I'm curious who you report to.
My direct report is the CEO,
Okay.
but that's not typical.
Yeah.
We have regional behavioral health directors
Okay.
who have functioned as both at some point in their life, BHCs and therapists, so they can supervise anybody. But and I'm acknowledging that we're an anomaly, right? Because we have training programs for interns and postdocs. So like I started as a postdoc 11 years ago. So
Yeah.
I've been trained in this model. And so now I can provide supervision um, in this model. Um,
Yeah.
we, as much as possible, will never have a BHC be supervised by someone who's never worked as a BHC. And I understand sometimes that's hard because you don't have the people to do it. I've done coaching with people who are a therapist who are about to have a BHC with like,
Oh,
what's the distinction between the two? And that's been helpful at times.
yeah.
Like reset your expectations. They will not come to you with, if we were still in DSM-4, you will not get a 5-axis diagnosis every single time. Like calm down. Doesn't mean they're not doing their job. It just means that's it's not that type of party.
Yeah.
Um, but BHCs supervise BHCs, therapists supervise therapists,
Okay.
the licensed people, you know.
Yeah. Yeah. We have a training program too. So we've got like pre-doc and post-doc interns. However, I'm an LCSW. So I'm sort of like on my own out here in my own little like, I'm just the social worker
So
floating.
the way it is here, and so notice I didn't say anything about degree, y'all. Like
Right.
we could
Yeah.
care less what your degree is. Can you be credentialed and can you do the job? That's all I care about. So
Yeah.
my job descriptions will say, you know, seeking a behavioral health clinician to work in primary care must be licensed or license eligible in the state of Tennessee.
Mhm.
Like, we never say hiring a social worker, hiring a psychologist. We never hire for that. We hire for the role, not the title. And so I have supervised LCSWs before, but in Tennessee, you have to like take a continuing education class that states that you know enough about, you know, social workers to provide that. But the majority of the supervision should come from a person who's already licensed as an LCSW. But we have maybe 2 strong LCSWs who have functioned as BHCs here. The rest are in training, right? And so we PhD people had to go get trained so that we could provide that supplementary supervision so they're not being overwhelmed in that way. So
Thank you.
sometimes you mix and match, just follow the practice laws of your state. But yeah, I absolutely supervise LCSWs at times.
Okay, thank you.
Mhm. We got 2 minutes, y'all. Anybody else got late breaking questions or news?
How do you
A
talk
quick-
to a patient if they think you're a traditional therapist? What do you say to them?
Yeah, so again, I have heard some introductions, y'all. Like, I have been introduced as a therapist, I've been introduced as a shrink. My favorite I've been introduced is like the crack taker aware. Like, I'm gonna have Dr. Winford come in here and she's gonna take your crack. And I was like, no, I'm not. Don't want it. Like, what am I gonna do with that? I don't want it. Um, so it's really helpful. Like, if your team is not using consistent language, you do have to spend a few seconds, minutes re-educating. And so my script is, no matter what, hey, I'm Dr. Winford. Nice to meet you. I'm a member of the primary care team. I work as a behavioral health consultant. Although I'm licensed as a psychologist, I don't do therapy like most psychologists. In fact, I'm a primary care team member. I work with your PCP, your nurses, everybody on your team to collaborate with you to come up with a plan to address the depression that you mentioned to Dr. Carter. Then I literally turn my laptop around and say, we document in the exact same medical record. It just helps us to stay on the same page so we can communicate well with each other and take care of you as well as possible. Give my limits of confidentiality, making sure that they know that confidentiality is with me and the team, not just me. And then I go back and say, so again, I'm going to work with you for about 15, 20 minutes, see if we can make a plan to address the symptoms of depression that you mentioned. Is that okay with you? But notice I really aim in the first intro, but sometimes patients like, wait, they said a therapist was coming in. I said, I know it can be confusing sometimes, you know, but my role here is this. If you ever want more, I have some colleagues that I can help get you linked in with, if you have that option. Other times you might say, unfortunately, we don't have the therapy that you may be thinking about, but give me a try. Like, let's try something first. You know, like, we can at least do something today. So your sales pitch, essentially.
And I think Samantha, you wanted to say something and you were muted for a bit.
Yeah, if we don't have time, that's fine. I was actually going to ask about the script that you just said. So you're good.
I can send it to Alina as well. It's really
That would
long.
be amazing.
It's long, but I give you the longest version first.
Comprehensive.
Yeah, the
Yeah.
longest version first, and then you make it work for you. But yeah, I'm
That would
very
be
clear.
perfect. Thank you.
Right after I say, hey, I'm like, hey, no therapy. I will hook you up with a really great therapist, but I'm an awful therapist. I can't do it. I tick in 15-minute increments. I can't do it.
Yeah. Thank you.
Mm-hmm.
Okay, I want to assume that it's safe to say that we're actually reached the end of our time, and I don't think if anyone has questions, but feel free to leave. Thank you, Dr. Winford, so much for presenting today. We had a great session. And remember, please fill out the evaluation surveys if you want your CEUs distributed. And we'll also leave details about our upcoming behavioral health consultant certificate course that Dr. Ebony Winford is actually a faculty member for. And we'll be launching the application soon. And we actually have another one of our faculty in our Zoom, Dr. Chris Hunter as well. So we're really excited to launch our 3rd cohort next year. So please be on the lookout. It is all virtual, so everyone from every state can apply if you already work in a primary care setting. And I have a question from Samantha. Our sessions are recorded, so we could send it to you on request, and these slides will be distributed to you in the follow-up email as well. But other than that, thank you all, and I hope you have a great day, and look out for the eclipse.
I'm gonna see if my computer likes me yet.
You feel better, Dr. Winford.
Thank you. Bye, y'all.
Bye.